Thank you very much, Dr. Samir. مساء الخير. السلام عليكم ورحمة الله وبركاته. It's very honored to be with you today or this night. I hope you are still fresh and awake. I think all of us got a lot of enjoyment with the last hour with Dr. Mu'taz's presentation. He was highlighting a very unique patient with a very challenging setting. Really, it's very interesting and enjoying. This night, the next hour, I hope not to be too late, we will highlight one of the very important topics in our practice, which is emergency obstetric situation that indicates ICU admission for obstetric patients. Is this okay, Dr. Walid? I am sharing my screen. It's okay?
All good. We can see your screen.
Okay, yeah. Thank you very much. What we will, as Dr. Mu'taz told us the last hour about a challenge in anesthesia of a special character patient in a special challenging settings. Today we will look for the mothers. We will highlight the most important points because actually most of the ICU topics are very wide to be covered in a lecture or a session. So we are actually highlighting the most important points, hoping to go more and more in depth for these topics. What the scale of our problem, how frequent we are facing this problem, and what's unique for our patients, what's unique for these pregnant ladies or immediate postpartum ladies, how we can identify that this lady is critically ill and needs our service as intensivists, and what are the special management should be given in ICU for them. And we will get some points about special pregnancy-specific critical illnesses that our obstetric ladies they might suffer. Let us go to overview for this one. We will have a freshing question regarding critically ill obstetric patient. It is very common in adult ICU to have an obstetric patient. We are seeing them commonly, or the maternal mortality rate is higher if ICU admission is needed. The fetal mortality rate is lower if ICU admission is needed, or that our patient's outcome is not related to the level of country income in which we are working. What do you think? Yes, it's not that much common to see an obstetric patients in our ICUs, unless you are working in a obstetric designated hospital and designated ICU for obstetric patients. It's not that much an everyday life to see an obstetric patient among our patients. But really the mortality is higher once this patient become critically ill up to need to be ICU admitted. And of course, the fetal outcome is very much related to that. And all the outcomes in those patients depends on the financial status or the country income, and how is it easy to access the healthcare for those patients. What's the scale of our problem? The incidence of ICU admission among postpartum women and pregnant women, of course, it's about 0.7 to 13.5 in 1,000 deliveries. 1,000 deliveries. The most of these admissions occur in the postpartum period, about up to 90%. The range looks very wide, between 60 to 90, and this is because according to the country income or the country financial status, it differs according to countries between developing versus developed world. But maternal mortality 3.4 up to 14. Same reason for this wide range of incidence. 3.4 to up to 14% of those ladies admitted to ICU, they might go into death. What we have to again and again highlighted and again think it's very important, and it is the key for success of the management, is to work as a multidisciplinary team. The intensivist versus anesthetist, of course, plus the obstetrician, and still there is a pediatrician and many other people we should include in the team. Fetal mortality is high when critically ill or critical care is needed for the mother, and it depends a lot on a lot of factors like gestational age, what is the mortality illness, the maternal illness and its severity. Severity of this illness, if she needs blood transfusion or not, if there was a perinatal care or not. A lot of factors affect the percentage or the incidence of fetal mortality for critically ill obstetric women. Okay, that's what it's about. So when to let the patient to be admitted to ICU, we have many factors let the patient in need for ICU service. It might be a general causes like sepsis, like trauma, or whatever, or something related to the pregnancy itself, and this is what we call pregnancy-specific cause of critical illness. Let us to have a look to this chart. It shows the incidence of causes of maternal mortality. This is a UK report. We can see thromboembolic, one of the among highest indication. And these are mortality in the mothers according to the countries. We can see that it's very less in the high income countries in comparison to lower income countries. In the bottom, we have Iraq and Yemen. This is the Egyptian maternal mortality ratio between 2006 and 2017, showing an improvement. We are the latest report, 2017, 37 deaths per 100,000 live births in 2017. There is an improvement in the maternal mortality. Now, how we can identify our patient? How we can to identify the patient and where to give the care to the patient? Let us to have this question. Regarding management of critically ill obstetric patient, it is the same as for any critically ill patient with no difference. Fetal outcome is independent of maternal condition, managed only by the intensivist in a closed ICU model. The presentation and management is altered by a presence of pregnancy. What do you think? Yes, of course, I agree with this. The pregnancy is really altering the presentation of the patient, and it makes some sort of difficulty to catch the patient in need for a critical care service. Regarding levels of care, this is the usual. If the patient is okay, stable, and everything can be done in the ward, no special needs, she will be in the ward. But if the condition deteriorating, necessitating higher level of experiences and closer observation, you might need to put her in a different place, and this is level 1. And if the patient system start to be jeopardized and in need for invasive monitoring or maybe intervention for one or more of the hair body systems, excluding respiratory, this may be level 2. But once the patient became in need for respiratory support, which is advanced respiratory support, this is a level 3. How to manage this level? This is different in different settings. I mean, you might serve level 2 and 3 in ICU. You might have like an intermediate care for level 2. You might have a higher, sorry for this, a higher care and maternity ward. You can even manage level 1. This is different between different organization and different hospital, but this is what's needed for the patient. Now we have actually a very unique concern for the critically ill obstetric patient. First of all, we have to tell that pregnancy and delivery can be a cause of critical illness. This is a fact. Critically ill obstetric patients are usually young and otherwise healthy. The management is really complex. You are managing pregnancy and critical illness and the baby. This patient in need of a combined requirements. We have 2 patients actually, the mother and her baby. And the level of care needs depends on the best evidence and practice, and the level of care should be decided by, as we told before, a multidisciplinary team assessment and management. This is not a single person decision. What about assessment and management? As we tell that pregnancy and what changes happen during pregnancy to prepare the mother for delivery and to let her to meet the fetal needs during pregnancy will really affect the management. First of all, physiological changes associated with pregnancy may alter presentation, may alter location where we find the patients, and different lines of management. This is what we just highlighted. Pregnancy specific conditions need special knowledge, special training. Presence of fetus or both mother and fetus affected by the pathological status. So what the problem the mother is facing, also her baby is facing. Fetal outcome improved by improvement maternal condition, but still maternal welfare is superior to that of the fetus. And clinicians, sometime if you are in a place where a mixed adult ICU, you might need to train your people, because as we told earlier, that it's not that much common to see an obstetric patient. It's not an everyday life. So training of intensivists should include obstetric critical care. These are some of the examples of maternity care required at different level. We will highlight later. And these are some of the physiological changes that happen during pregnancy. It is a lot, and too many, but this is one of the most important that we are really affected by. Let us to see what is the most important. For example, changes in lung functions and diaphragmatic splinting by the pregnant uterus as we are going in advance in pregnancy. This might affect the patient, the mother now she's not a patient yet, the mother oxygenation. It will increase oxygen consumption to meet the fetal requirement, and this will affect the capacities, especially functional residual capacity of the mother, and let her more prone to be hypoxic in any situation. So hypoxia is really and more rapidly happen during the periods of hypoventilation. This is very important when you are anesthetizing this patient or we are giving a respiratory or support to her. Risk and incidence of difficult intubation is higher in the pregnant ladies because of the edema of the airway, and there's also some sort of difficulty because the enlarged breast with the advancing in the pregnancy. There is increased risk of aspiration. This is a nightmare for every pregnant lady. Aspiration is common. This because of hormonal effect on the cardiac sphincter and increase in acidity with compression by the pregnant gravid uterus. Aspiration is a real risk for the pregnant mother. Also, pregnancy is by default a hypercoagulable status, put the mother at risk of venous thromboembolism. This is a diagram to show the difference in different lung capacities. I think it's very nice, this one. And on the right side, the mother, the pregnant ladies, on the left are non-pregnant condition. What else regarding physiological changes as regard the cardiovascular system? Aortocaval compression, it is a common problem, especially in the last trimester. The gravid uterus compressing the aorta and the inferior vena cava, leading to decreasing cardiac output. This is once the gravid uterus coming above the umbilicus, so from 20th weeks of pregnancy and onward. And this will be of a great impact to our management. It leads also to supine hypotension sometimes. So if we are resuscitating a mother because of hypotension or because of cardiac arrest, we have to take this in consideration and try to displace this compression of the aorta and inferior vena cava by displacing the uterus. This can be either by manual displacement, some assistant will push the uterus away, or by letting the mother to be in the left lateral tilt. This is very important and very effective. Actually, this problem might hinder the response to CPR, and it might delay return of spontaneous circulation. And in this situation, you have to go for manual displacement of the uterus and even perimortem hysterotomy and delivery of the baby. Actually, the mothers usually are on hypotensive side, so be careful when you are evaluating a pregnant lady for hypertensive problem. And telling that the mother is having a pregnant lady having a high output status, this means a large blood volume can be lost rapidly. And so we have to manage blood transfusion more wisely for the pregnant ladies. So let us to have a look for blood gases in late pregnancy. Usually pH 7.43, it's okay. Partial pressure for CO2 in arterial blood is low, 30 by hyperventilation. Oxygenation is usually okay. And bicarb is a little bit low to compensate for this CO2 wash. So we have a decreased oxygen reserve due to decreased functional residual capacity and increased oxygen consumption. Remember always, our patient is not well tolerated hypoventilation or apneic condition. What about the risk to the fetus if we are dealing with a critically ill obstetric patient? Remember that fetal hypoxia is of a real importance when we are facing critically ill pregnant lady. Radiological investigation should be taken with cautious, and drugs, what we are giving to the mother is should be considered. We have to consider the fetus in our decision if it is possible. We need to identify the patient, and there are some warning signs and symptoms, the usual for any patient. It might be the same or a little bit modification. Let us to have this question. Regarding warning signs and symptoms in critically ill obstetric patient, systolic blood pressure around 140 millimeter mercury is accepted. Metabolic alkalosis is a common finding in the last trimester. Persistent, non-relieved headache is alarming. Temperature of 38 is accepted due to progesterone hormone effect. What do you think? Agreeing. Okay, this has to go. This is some of the early warning criteria. You can find some difference in different institutes based on protocol done, but we are including the vital signs: systolic blood pressure, diastolic blood pressure, heart rate, respiratory rate, oxygen saturation, urine output, of course, behavioral or conscious level changes, and other symptoms like persistent headache, with the question, persistent non-relieving headache or persistent non-relieving complaint, you have to consider alarming. This is some of the early warning scores are used in different countries or different organizations. What the consideration we have to use while we are managing critically ill patient, critically ill obstetric patient, of course. Regarding ICU management of critically ill obstetric patient, all are true except rapid sequence induction is a rule. You must be ready for difficult intubation. Ionized radiation is completely forbidden with no exception. Left uterine displacement is of great help. Yes, ionizing radiation is really not not advisable except in a very, very limited situation. You can forbidden like that if it's needed, and there's no other alternative you might go for to take the risk. So what is next? Let us to see some point. The following recommendations are based on a limited or inconsistent scientific evidence. We have that when the mother in need for a medication or a diagnostic imaging and there is no other alternative, and this is the only way to diagnose or to treat, you have to go and accept this risk, of course, after discussion with everybody in the multidisciplinary team. If effort to resuscitate a pregnant woman in a cardiac arrest unsuccessful, we mean a pregnant woman more than 20 weeks, we are afraid of the aortocaval compression. And you might decide to go for resuscitative hysterectomy and deliver the baby on the spot. Of course, you are not moving the mother, and you have to make this as an emergency base while resuscitation effort and chest compression is going on. This is to let risk or return of spontaneous circulation having a chance. Yeah. Okay. When higher level maternal care facility is required, I mean, if you are in the maternity and then you need to push the patient to intermediate or intensive care or intermediate care, and then you need to admit the patient to intensive care unit, and you have to consider the risk during transportation. You have to consider the monitoring during transportation and transport as soon as possible, making everything safe during transportation. Decision on fetal monitoring during transport or during the whole management is a decision of a multidisciplinary team based on a lot of factors for the baby and for the mother. Where to put the patient, to admit to ICU, intermediate, or to keep in the maternity, or to put her in the delivery ward. This, again, a multidisciplinary decision after a proper assessment of the patient. And whatever risk will be taken, the family should be considered, and the patient, of course, if she can decide. If we are in need to make something risky to the baby for the sake of the mother, this should be a shared decision between medical team and the patient and her family. Initial evaluation and resuscitation of obstetric patient is the same. We have to follow ABC's guidelines, airway and then breathing and circulation and so on. Remember about uterine displacement, left uterine displacement, manual or by putting the patient in left lateral tilt. Be careful about the baby. Don't forget there is a fetus. You have to monitor. You have to keep safe. What about the monitoring of the obstetric patient? The basic standard monitoring, of course, like any critically ill patient, you might need invasive monitoring, and this depends on how many systems affected or what are the systems affected. And the fetal monitoring should be included in the monitoring of the obstetric critically ill patient, especially if more than 24 weeks gestation, and this might give a clue about the time to deliver the baby. Is there any special mortality prediction scores like Apache or other we are using? We have a physiology-based score like Salwa, very reliable because of the physiological changes in the mother. There is some specific obstetric score, especially for sepsis, and we can still use the organ failure-based score like SOFA and multi-organ dysfunction score, and this might be of a great help. When to deliver the baby? When to deliver the baby? It's an area of a great controversy. When the baby is viable, to deliver him, or one let us to keep everything to nature until so long the mother is stable and we can keep the baby inside. Decision is really influenced by viability of the fetus, by if the mother will get benefit or not, and the fetus will benefit or not or get harm of this of the delivery decision. And we have to tell what method of delivery. You will go for normal vaginal delivery or you will go for CS. We have problems like coagulopathy, like hypertensive problems, like a lot of problems that put the patient in a critical illness you have to consider. And still, this is a multidisciplinary decision done in collaboration with the intensivist, obstetrician, and pediatrician or neonatologist, actually, including the mother and the family. It is guided by obstetric indication. What about ventilating a pregnant lady? What about ventilator strategy used in obstetric critically ill patient? We are using positive pressure ventilation, either non-invasive or invasive. Actually, it's very similar, the indication, and very similar, the contraindication for non-invasive. For example, you cannot get put non-invasive ventilation for a patient with disturbed conscious level, for example, or hemodynamic instability. think about when you are deciding, think about the risk of difficult intubation. It's a real risk. If you are about to intubate, be ready with difficult intubation tray settings, and the intubation should be done by the most expert person. And be ready with a smaller size tube, because as we told before, there is some edema of the airway, make the proper size is not easy to go. So you might need a smaller sized tube. And think very, very, very quietly about risk of aspiration. So go for whatever anti-aspiration measures. Rapid sequence induction with cricoid pressure is a rule. Think about the risk of hypoxia. The patient is easy to go for to be hypoxic. So pre-oxygenate, and again, intubation by an expert person. Remember that sedatives cross the placenta, how you are close to delivery. I'm speaking about intubation in the ICU. And if we are close to delivery, or the delivery decision will be made soon, so a neonatologist should be involved about what sedatives we used. So to be ready to work with the baby, as all sedatives we cross the placenta and might lead to fetal sedation and apnea. Actually, this will be later highlighted. The prone positioning can be with pregnancy, still very difficult, but can be. And ECMO can be with pregnancy. We will highlight this later on. This is a blood gases between non-pregnant and pregnant, the first in comparison, first trimester compared to second and third trimester. We are seeing that CO2 is decreasing by time, and bicarb is also decreasing by time in pregnancy. Oxygenation is okay, but the patient easily to be hypoxic if she is hypoventilated. When we are going to intubate and put the patient on mechanical ventilation, what goals we need to achieve? We need to achieve peak inspiratory pressure less than 35. We need to plateau pressure less than 27 to 30. Driving pressure, which is the plateau minus the beep, less than 12. We need to keep adequate arterial blood gases. Oxygen tension between 60 to 100 millimeter mercury. Carbon dioxide between 28 to 32. We don't like to put the patient into hypocapnia, because this is hazardous to the placental blood flow, or hypercarbia, because this might lead to fetal acidemia. And oxygen saturation between 94 to 98. And this is the pressure that appears on the ventilator interface. We might go for lung protective strategy, and 6 ml per kg of predicted body weight, of course, as calculated. Plateau pressure less than 30. P value, you can give more than 5, and be careful with the P value, and intravascular volume or affection, the effect on the hemodynamics. Driving pressure less than 12. And recruitment maneuver is not that much okay in pregnancy, but if it needed for the sake of the mother, is no other alternative, you might use it. BF ratio less than 150 is indication for proning. And again, we will highlight this later on in this presentation. CO2 management, as we told, we have to avoid hypocapnia, which is less than CO2 arterial CO2 tension less than 25 millimeter mercury because of uterine blood flow. And we have to avoid hypercapnia. The mother will be in respiratory acidosis, and this will be fetal acidemia. Actually, it was mentioned in some studies that it's up to 50 to 60 millimeter mercury is okay for the mother. Yeah, this is still a controversy, and work according to your scenario. Prone positioning in obstetric, it might be difficult, but it's not. It is still possible. It is, of course, little studied, especially in nowadays with the pandemic of COVID-19 and the need for prone positioning. There's no contraindication. You can still prone the patient. You can still also make everything safe for her if you have ARDS and refractory hypoxia. Of course, the team should be trained. Actually, the team should be trained for proning for all patients, and especially for this unique, challenging patient. There is a lot of reports, especially with the pandemic of COVID-19, and these reports, actually, it is not that much large number of patients, but still there is a successful proning from second and third trimester patients, and with good effect on oxygenation. It works nicely in pregnant, like non-pregnant patient. Sorry for this. This is a proning. We can see down the mothers proned and how it affected BF ratio, and this is the way how we are proning using the sheets and almost 6 individual, 3 on each side, plus the one managing the endotracheal tube, and this is the patient in proning position. And this a lady proned awake that we are doing very frequently in COVID-19 pandemic to prone awake patients. What about the use of antimicrobials and other pharmacological agents in pregnancy? The rule is to avoid whatever harm the baby if it is possible, unless there is other alternatives. We can use this for the sake of the mother. Of course, there is a lot of drug category as regard the fetal affection, A down to D, regarding what teratogenic, what others not teratogenic. It's again a multidisciplinary approach, including the team, intensivist, obstetrician, and neonatologist. Nutrition in a critically ill obstetric patient is of great importance, as all critically ill patient. Nutrition is a key factor in success of the management. So it is of utmost importance to the mother and the baby. If there is a specific nutritional needs, we have to work on it. Intra-root is still the default for the pregnant mother, like all critically ill. This extra calories is needed during second and third trimester, and increasing protein needs. You have to consider kinetic and aspiration risk for the pregnant mothers. Regarding TBN, you have less data. Consider degree of stress while you are calculating calories and needs. It's a multidisciplinary approach once more. If there is extra needs of vitamins and minerals, you have to supply. Thromboprophylaxis, as we told that pregnancy is a hypercoagulable status, and remember that the patient at high risk of VTE, especially in the, again, era of COVID. Thromboprophylactic is needed once patient in ICU. Make this as a multidisciplinary again. What about cardiopulmonary resuscitation? Let us to remember the same high risk of difficult intubation, of hypoxia and acid aspiration, and survival of the fetus depend on the adequacy of maternal resuscitation effort. Maternal resuscitation follow the guidelines as the usual for any adult cardiac arrest patient. After 20th week of pregnancy, consider manual displacement of the uterus. This is the manual displacement of the uterus, and resuscitation hysterotomy whenever needed. And this is the guidelines, ACLS guidelines. And this is a picture for the manual displacement of the uterus to the left, and left lateral tilt by the, we are using like sheets or something below the trolley, the board, to make the patient on the left lateral position while resuscitation and chest compression is continued. In the coming slides, we will highlight some of the pregnancy specific critical illnesses. Let us to see, the mother might became critically ill because of the pregnancy, and like peripartum hemorrhage, obstetric sepsis, preeclampsia, amniotic fluid embolism, acute fatty liver of pregnancy, or she might become critically ill because of a medical illness that aggravated by pregnancy, like being aspiration, pneumonia, venous thromboembolism, pyelonephritis, whatever pneumonia and chest infection, connective tissue disease, cardiac disease, diabetes, or it's non-specific like having trauma or respiratory failure for whatever reason. We will highlight some of pregnancy-related critical illnesses. Let us to go for this question. Regarding pregnancy-related critical illnesses, most common cause are maternal hemorrhages. Acute fatty liver pregnancy is very common in Asian ladies. Delivery of the fetus is not adding to maternal management. Amniotic fluid embolism is common postpartum problem. What do you think? Yes, I agree. It's the most common cause is maternal hemorrhages, of course. Just to have a look for the other causes. Obstetric hemorrhages, it is almost the cause of 30% of maternal mortalities in low-income countries. Majority of this hemorrhages is coming in the postpartum period. Hemorrhages can be of various causes. It might be because uterine atony or placental abnormality, uterine rupture, some surgical or genital tract trauma during delivery. This is abruptio placentae. And on the other side, this abnormal placental sitting, placenta previa in its different types. All these are causing maternal hemorrhage. Of course, the patient, if the hemorrhage is severe, she might go into hypovolemic or hemorrhagic shock. We have to think about vitals data in this patient. We have to control source of blood loss. This is of utmost importance. Otherwise, we are really losing the patient. We have to restore oxygen carrying capacity, and we have to maintain tissue perfusion. How we can make this one? Initially, immediate IV crystalloid resuscitation. Of course, replacement of lost blood by packed RBCs transfusion, and coagulation factor platelet replacement. Some advise that to have immediate accessibility to blood and blood products and coagulation factor, we might implement a massive transfusion protocol, and they make this protocol the protocol when managing a severe peripartum hemorrhage, so we can get immediately access to platelets and coagulation factor in addition to packed RBCs. Control source of bleeding can be by different methods. Can be medical by giving drugs can enhance uterine contraction, or mechanical by compression, or surgical, and surgical might be conservative like embolization of internal iliac or whatever, or hysterectomy if it is everything failed. Again, there is to catch the patient and to assess the severity of hemorrhage, shall we use the usual vital signs, heart rate, blood pressure, and so on, or some suggesting Some suggesting that using shock index, which is the ratio of pulse to systolic blood pressure, for detecting hypovolemic shock secondary to obstetric hemorrhage is superior to the conventional vital signs. So we can escape the problem with the changes in the physiology of heart rate and the blood pressure during pregnancy. Uterotonic agents can be used, uterine massage also. This is the way how to stop bleeding. We can make a controlled cord traction, cell salvage, early aggressive coagulation support, intrauterine balloon tamponade, mechanical compression, uterine artery embolization or ligation, up to hysterectomy if no other way. This is the number of hemostatic surgical procedure taken in case of major obstetric hemorrhage. There are a lot of studies. They are comparing different techniques of mechanical tamponading and surgery. It found no difference. Actually, what you can do it to save the patient's life. We will go for maternal sepsis. Maternal sepsis, like cardiomyopathy, is a real problem, and it presents 15% of maternal deaths worldwide. Septic shock can be seen, and if the cause of sepsis is pyelonephritis or chorioamnionitis or endometritis, outcome of the patient is better, actually of the pregnant is good, non-pregnant, because once you are removing the source of infection, she's an otherwise healthy patient. In most of the cases, she's young and healthy. Because of the uteroplacental circulation does not have autoregulation, so the infection can be easily transferred to the fetus from the mother to the fetus, and it will really affect, worsen the outcome of the fetus in this situation. We will manage the patient as survival sepsis campaign in case of septic shock, giving antimicrobials as protocoled, and of course as culture later on. And this is some of the proposed scores for the obstetric patient in special sepsis in obstetric score, or you can use multi-dysfunction score, SOFA score. Hypertensive disorder in pregnancy, this is another and very common problem. It's common among pregnancy-induced problem in the obstetric patient. The goal is that tight control. Actually, we have to control blood pressure very tightly and keeping the goal of keeping the diastolic blood pressure between 80 and 85. Let us to remember the mother is usually on hypotensive side. The normal for her is 90/60. This is the normal. So if you are going to 140, you have to be alarmed. The pathophysiology in this hypertensive disorder, namely preeclampsia and eclampsia, is because of poor placental perfusion and some problem in the vascular endothelial dysfunction at the mother side. We have mild and severe preeclampsia. The mild preeclampsia less than 37 weeks. Actually, it's not usually our task. It can be managed in the ward, and we can manage expectantly the mother and the baby. Remember that magnesium sulfate, we are giving magnesium sulfate in severe preeclampsia as a prophylaxis against fits and eclampsia. Again, preeclampsia, the incidence between 5 to 8%. It's a syndrome of hypertension, proteinuria, and edema. It can be mild or severe. This is the criteria of severe preeclampsia. And the management, the usual is well-timed delivery of the fetus. We can see here in all these problems regarding related to pregnancy and occurring in the prepartum, the delivery of the fetus is a solution, is a real and a very good solution. So plus delivery of the fetus when possible, controlling blood pressure, and this is some of the examples of antihypertensives used to control blood pressure. And remember that fluid therapy management is very important for this patient, because in real, this patient is deficient in the intravascular volume. You have to give her volume and be wise not to put her on decompensation. Patient usually fluid depleted, but careful fluid loading needed, and consider monitoring. And don't forget to give seizure prophylaxis by magnesium sulfate, and the usual dose 4 grams IV loading, followed by 1 to 2 grams per hour, and followed up by serum level and other follow-up criteria. And this is the complication of preeclampsia, a lot of complication actually, if not well treated. And we will go to one of the complications of preeclampsia, and it can be a nightmare for the mother, HELP syndrome. HELP syndrome stays for hemolysis, elevated liver enzymes, and low platelet count. Hemolysis, this demonstrated by elevation of lactate dehydrogenase, more than 600 international units per liter, increasing indirect bilirubin level. And if we are having a blood film, we can see schistocytes. It's a characteristic of hemolysis in HELP syndrome. Elevated liver enzymes, transaminases, more than 72 international units per liter, and platelet count less than 100 per cubic millimeter. It comes about 4 to 12% of all preeclampsias. It's a real complication, a nightmare for a preeclamptic patient. If the patient is undelivered, and it comes while the patient is still pregnant, please do deliver the baby. This will solve the problem in a very good percentage of the population. Same management, like depends on the patient viability, multidisciplinary approach once more. So delivery, this is the first line of treatment of the HELP syndrome. Treat preeclampsia, because it's usually complicated preeclampsia, and give blood, platelets, coagulation factor in the ratio like massive blood transfusion, and do liver support. Please do liver support, and be careful about medication that you are giving to the mother and her liver. Plasmapheresis may be of value if more than 72 hours postpartum. This is for postpartum patients. And steroids was suggested in some studies, but actually it is not proper to give steroid. You need to deliver the baby and replace coagulation factor, support the mother. We will go for another pregnancy-specific condition, amniotic fluid embolism. It's a rare condition, alhamdulillah. It's a rare condition, but it's really devastating emergency. Patient typically presented with acute onset of severe hypoxia, change in the mental status, and collapse, cardiovascular collapse, and maybe up to DIC. Diagnosed by exclusion. There is no special test used in a common practice to diagnose amniotic fluid embolism. It is diagnosed by exclusion. Usually, the most common, it is intrapartum, but still can be immediately postpartum, a cause of hypoxia. Improving diagnosis, improving supportive measures might lead to, it is what was mentioned, that it improves mortality, even that, so it's still high, the mortality is still high with the amniotic fluid embolism. It includes that amniotic fluid passed to the maternal circulation with all its content of the fetal debris, fetal urine, fetal hair, and everything in the venous blood. It is recorded that this hypoxia with amniotic fluid embolism caused the long-term neurological sequelae in the mothers. As we told, like, we have to deliver the baby, use ABC's technique, and manage as any pulmonary embolism by supporting technique for the patient. ABCs manage airway, breathing, and circulation. And if there is any cardiovascular collapse, manage this way. If there is coagulopathy, you have to manage it. Acute liver, fatty liver or pregnancy, it is a rare condition. It's uncommon, 1 in 15,000 pregnancies. It appears like the onset in the late third trimester. Patient comes with some GIT upset and jaundice, abdominal pain. It might advance up to coagulopathy, encephalopathy, and renal failure. We have to recognize this patient early so we can get a better outcome. This is the supposed pathophysiology. There's a theory about this, the mother carrying a fetus homozygous for a specific mutation of long chain 3-hydroxyacyl-CoA dehydrogenase, and this is the problem why the mother got this devastating condition. Again, the solution is to deliver the fetus and deliver the baby and give the mother support. No reversal, unfortunately, without delivery. Usually there is improvement after delivery of the baby, 2 to 3 days. The good luck that we are usually near the term, and so we can deliver the baby safely. Be careful of the placental damage and the baby, and then give supportive measures for hepatic failure. Give specific measures like plasmapheresis, it's still mentioned. And if no improvement after delivery of the fetus, there is no other solution other than liver transplant. Peripartum cardiomyopathy, it is a cause of heart failure in peripartum, late pregnancy, or up to 5 months after delivery of the baby. There is a criteria to diagnose peripartum cardiomyopathy, that the heart failure within the last 4 weeks, last month of pregnancy, and within 5 months of delivery. The patient should not have any cardiac illness before, and no other cause for this heart failure. And left ventricular systolic dysfunction is the diagnostic for this situation. It is a supportive measures like heart failure. Etiology here is not actually known, but some telling about some sort of immune response against the fetal antigens. Occurrence of peripartum cardiomyopathy during pregnancy is difficult to pick the patient, because actually all signs and symptoms of heart failure can be in a normal late pregnancy, in the normal pregnant mother in the third trimester or near third. So it's really difficult to diagnose. It might be more diagnosed postpartum. Give supportive measures, and a heart failure, anti-heart failure measures, the usual. You might go for dopamine, dobutamine, digoxin if the patient is hypertensive. Don't forget anticoagulation and antiarrhythmic if needed. Now we will highlight, it's 1 or 2 slides only for the current pandemic of COVID-19 and pregnancy. It's very important because we are still seeing many cases of COVID-19. The last week I have patient diagnosed as COVID-19 positive immediately postpartum, few hours after delivery of her baby. She got hypoxia and unfortunately also myocarditis. COVID-19 was positive by PCR test. So still, we are still affected by this pandemic, and in the pregnancy, it might be having a different setup. The pregnancy and childbirth generally do not increase the risk of to acquire COVID-19 infection. It is not increasing the risk to get the infection. There is a systemic review including 11,000 pregnant ladies was suspected and confirmed COVID-19. This gives 4% of these 11,000 was in need for ICU admission, 3% received invasive ventilation, 0.8% received ECMO, and 0.6% unfortunately died. Assessment and evaluation is the same, like in COVID. Complication like that. We have to differentiate COVID-19 infection illnesses like hypercoagulable status and VTE like that. We have to put in mind other differential diagnoses. For evaluating a pregnant patient with the COVID-19, chest X-ray can be used. Remember that one chest X-ray is not very much harmful. It's a low dose of radiation exposure. If you are in need, go for CT. Still, CT is, if you are doing once, it's not that much harmful to have this dose of radiation as per guideline. And you might also use ultrasound of the lung as alternative for both of them. Again, we will apply the rule. We are not going to do not indicated examination. I mean, we have to think 100 times before going to radio examination, either chest X-ray or CT chest. But once needed and there is no other alternatives, we have to go. It's not that much harmful to get one examination. The management, the usual. Actually, the oxygenation target saturation more than 95%, arterial oxygen tension more than 70 meter mercury, by whatever mean. In severely ill patient, if the oxygenation is not achieved, go for proning if BF ratio less than 150. And again, proning, it might be a little bit difficult during pregnancy, but it's still working and still possible. Be careful of aortocaval decompression, or do aortocaval decompression. High BP strategy we can use, consider volume status and hypotension for fetal monitoring. Permissive hypercarbia, if we have ARDS and we will go for lung protective strategy, still we can do it with a little effect on the fetus. Let us to remember that anticoagulant is of great importance in COVID-19 and pregnant ladies, both of them, hypercoagulable status, but manage well if we are about to deliver the baby. What about steroids, glucocorticoids? It can meet the needs for the mother to improve oxygenation and at the same time the baby, to push him towards maturity so we can let the baby out. Other lines like remdesivir and remdesivir by itself is okay as for the pregnant ladies. Convalescent plasma is still no objection. Actually, data are very much less. We are new for this setting, and so again, it is a multidisciplinary approach. Consider the discussion with the clinical pharmacist and other members in the team, and prioritize the mother welfare. Chloroquine, hydroxychloroquine, it is not that much efficient as per a lot of guidelines, and remember it had side effects to the mother, and it might cross the placenta, and in animal studies it leads to the fetal corneal deposit. Fetal monitoring of utmost important. It is very important, and decision of delivery is very important. Fetal delivery is a very big question mark. So, what is take-home message for today? Critically ill pregnant mothers are unique, of course. They are a special category of people. Do not forget the baby, do not forget the fetus, and manage as multidisciplinary team. You are not alone. And when there is no alternative, always choose the mother. Thank you very much for being here. Sorry to be very late. Thank you.
Thank you, Dr. Salwa. Really attractive.
Thank you, Doctor.
And a good review. think we covered all.
الو
الصوت واطي شوية يا دكتور سمير معلش.
Thank you. You hear me now?
Yes, it's a little better.
Yes. Thanks, Dr. Salwa, for this attractive lecture. It is a good review.
شكرا.
You told us about general strategy of how to manage obstetric complications in ICU. And from general strategy, you shifted to a specific strategy for toxemia, for health, for amniotic fluid, for COVID. And I wanted to add a message about COVID syndrome. It is sometimes giving the same pictures as health syndrome. And so our message, don't be hurry in delivering the patient who suffering from COVID and giving the picture of health syndrome. Just support the patients and he will improve just after pneumonia subsides. Really a good lecture. And I think we have
Thank you, doctor.
no questions, because you cover all the questions which you want. There is one question.
Or it's very late and everybody is tired.
Yeah, no questions really. You answered all the questions about the
طيب الحمد لله.
obstetric complications. You have the talent to cover the topic extensively. Really. Thank you, and I leave the mic to Dr. Walid if he has any comments. Thanks for you.
Thanks very much for all colleagues tonight. Again, we are beyond time for 19 minutes, so my sincere apologies for that. Lectures were really interesting, so we had to stay and not to interrupt. So my full appreciation and my sincere apologies. And last thing, see you next week with two of the anesthesia and ICU lectures. Next week, next Saturday, will be the week number 19 with anesthesia for neurosurgical procedure with Dr. Walid Ali. He was the very first speaker talked in this session, and he talked to us this first session on communication skills in anesthetics. And the second lecture will be in tumor lysis syndrome from Dr. Adel Hussein. I think he covered 2 or 3 topics previously. So see you next Saturday, and thanks for our eminent speakers for tonight, Dr. Salwa, Prof. Salwa Khattab and Prof. Mu'taz Abdurrahman. Thanks for the moderator of the session, Prof. Samir Ansari. See you all next week, inshallah. Thanks very much. Assalamu alaikum wa rahmatullahi wa barakatuh.
عليكم السلام ورحمة الله وبركاته.